Good evening, everyone. This is a case of fever and jaundice with hepatomegaly. Master Y, 12 years old male child, firstborn of third-degree consanguineous marriage, hailing from Chennai, brought by his mother, whose reliability is good, with chief complaints of yellowish discoloration of the eyes, high-colored urine, pale-colored stools, and itching for the past 2 months.
1 minute. Niveda, here I am sorry for interrupting you in the first slide itself. All the three complaints are there for the past 2 months. Am I right?
Yes, ma'am.
Or you want to, or jaundice for the past 1 month, high-colored urine, pale-colored stools for how long? Can you just categorize them as to how many, or all three are present together since for the past 2 months?
As per the history, it was present for the past 2 months.
Okay, proceed. Why I am asking is, when do you call it as acute hepatitis? Usually, what is the duration for us to call it as acute hepatitis?
Less than 2 weeks of presentation, ma'am.
Acute onset of liver dysfunction, not 2 weeks, over a period of 4 weeks. This is over a period of 4 weeks with elevated liver enzymes with or without synthetic dysfunction. For example, OTPD elevated acute hepatitis is usually 4 weeks. We call it as acute hepatitis. In this child, the whole presentation is for the past 2 months, according to you. Okay. Okay, proceed, Niveda.
History of presenting illness. The child was apparently normal before 2 months. Then he developed yellowish discoloration of eyes, first noticed before 2 months. Insidious onset, gradually progressed to the present condition, associated with high-colored urine, pale-colored stools, which has gradually become normal 2 days before coming to our hospital, associated with itching for the past 2 months.
Okay, what is the inference from this slide? It's an important slide. High-colored urine, pale-colored stools, child is improving, itching is there for the past 2 months. What is high-colored urine and pale-colored stools indicate what?
It is a cholestatic presentation.
Cholestasis beyond infancy. That is entirely a different etiology. You are having high-colored urine and pale-colored stools, but an important history which you have given here is child has already started improving. Okay. Child cholestasis, it is conjugated hypobilirubinemia or unconjugated hypobilirubinemia? Conjugated. Okay.
It is conjugated.
Conjugated hypobilirubinemia.
Why the urine is high-colored here, Niveda?
Ma'am?
Why the urine is high-colored? Can you think of hemolytic jaundice?
Ma'am, it is due to urobilinogen, ma'am.
As you said, cholestatic jaundice means
due to increased
conjugated bilirubin. Yeah, it is water soluble, no? So that is the reason you don't get high-colored hemolytic jaundice. That's the one thing which differentiates that from a hemolytic jaundice versus your hepatocellular cholestasis or biliary cholestasis. So the high-colored urine, it is not a hemolytic jaundice. And second, stool color is also pale. That is also a very important thing. And the history which you have given is normal 2 days prior to coming to hospital. That means it is a transient cholestasis. That important is very important. Yeah. Okay, proceed.
You're ruling out syndromes which can produce intrahepatic congenital cholestasis. That we are ruling it out. Okay, go proceed. Yes. Next slide.
Initially, he developed a fever for 2 days, sudden in onset, low grade, intermittent nature, not associated with chills and rigors, no diurnal variation, no aggravating factors, relieved by oral medications, and the child was active during the afebrile period.
Okay.
Jaundice was associated with abdominal pain and vomiting. Abdominal pain for the 2 days at the onset of illness, gradual onset, static and intermittent, diffuse in nature, not radiating, no aggravating factors, relieved by oral medications.
What is the relationship between fever and jaundice in this child? What I'm trying to ask you is, fever resolved, jaundice appeared. Or what happened? Any relation? And does it carry any importance?
It can be a prodrome symptom.
No, for example,
infection causes, ma'am.
No, no. For the probably regarding the etiology also, you can come to a conclusion. Fever is, for example, you take up measles. Measles is a disease known to you. As soon as a rash appears, what happens to the fever? Usually, fever
disappears.
in varicella, what happens? For every episode of fever, a new crop of vesicles appear. In the same way, what happens in a case of hepatitis A? Fever disappears, jaundice appears, or fever is there along with the jaundice. Any clue? Can you have any idea?
Fever disappears, jaundice appears.
After fever disappears, jaundice comes.
Disappears. Okay. Whereas what happens, for example, other cause of hepatitis, for example, in cases of enteric fever, what is there any jaundice when you have hepatitis? Can enteric fever have hepatitis?
Yes, ma'am.
Do you have
Typhoid hepatitis.
do you have obvious jaundice in case of enteric fever?
No,
Or
ma'am.
anectic hepatitis mostly?
Anectic
Anectic
hepatitis.
hepatitis. It's a very good guess. Yes, it is an anectic hepatitis. And what happens? What is the relationship in leptospirosis, fever, and jaundice?
Jaundice persists during
Because
fever.
jaundice appears.
Jaundice persists for more than 2 weeks. And fever is also there. Fever and jaundice persists for a long period in leptospirosis. So now we know the relationship between fever and jaundice. In a case of hepatitis, once jaundice appears, mostly fever disappears. Okay, proceed.
1 minute, madam. Niveda, as madam said, in A, usually the fever subsides, unlike E. In hepatitis E, the fever may be prolonged. Second, in acute hepatitis A, if the fever is prolonged, you think of always a dual infection in tropical countries like ours, where you can have lepto plus A, or even malaria plus hepatitis A, or entry with hepatitis A. So when A is there, usually fever will not be there. And if hepatitis is there and the fever for a longer time, consider dual infections, or even E, hepatitis E, the fever may be even long. And also in obstructive jaundice, because there is hyperurine, there is pale stools. The pale stools is persistent. The abdominal pain and fever is there. You can even think of an obstructive cholestasis. So fever can be part of charcoal striated in a case of obstructive jaundice. And part of infection, you have to think of some etiology, whether it is transient like A, or long in terms of E, or dual infections with A, or sometimes A can trigger an autoimmune hepatitis where the child can have fever for a longer time. So these are the important things you have to keep in mind. Proceed.
Good.
Vomiting. 2 to 3 episodes lasting for 1 day on the day of onset of fever, contains undigested food particles, non-projectile, non-bilious, and not bloodstained, relieved by medications.
Okay.
For the above complaints, on the 2nd day of his illness, child was admitted and treated at Institute of Child Health for 3 days. He was said to have some infection for which he was prescribed tablets said to be Utka by his mother for 2 weeks. The child was asked to come for follow-up, but they didn't come for follow-up and discontinued tablets after 1 week. His complaints persisted, and since he was not able to tolerate itching, he was taken to a private clinic where he was given IV medications for 3 alternate days on OP basis. Following this, he took native treatment, which was a ground leaf paste, for 3 weeks. Throughout the duration of 2 months, his complaints of jaundice and itching persisted, which has become normal before 2 days coming to our hospital.
Okay, Niveda, I will stop here. What has happened to this child, Niveda? This child was probably, what do you think? Child had 2 days fever, child developed jaundice, child was admitted, child got discharged from ICH. So this is a short duration of illness child has had. So what is it likely to be? From the it is likely
it could be a viral hepatitis.
Probably.
What are the types of viral hepatitis you know of? A,
B, C, D, E. Ma'am.
Okay, now are we talking about any B and C at present?
No, ma'am.
No, you are thinking in terms of A or
Yeah, E, ma'am.
Okay, A or E, and more commonly
A, ma'am.
you are thinking in terms of A. Do we use what is it for the treatment of hepatitis A? Do we routinely give UDCA?
No, ma'am. Since he had a itch, he could have been started on UDCA. Ma'am.
He could have been? No, he was admitted at hospital. he had any problem during in the hospital, ICH itself, did he have any problem? Why was UDC? What is the treatment routinely prescribed for hepatitis A? Any specific treatment?
Supportive management only, no.
Very good, supportive.
Very good. Supportive is the treatment. Excellent. Okay, so he was prescribed UDCA, but what is the role of UDCA in hepatitis?
UDCA is going to be having cytoprotective effect on the hepatocyte-induced, bile acid-induced damage on the hepatocytes now.
Okay, so
And the antioxidant properties
What is
and
UDCA?
antipruritic treatment.
Very good answer. What is UDCA?
Ursodeoxycholic acid.
Yeah, what is it actually?
Bile acid, ma'am.
I know it's bile acid.
Cholinergic agent.
Cholinergic agent, ma'am.
It is a tertiary bile acids and it is hepatoprotective. Okay, it replaces the toxic hydrophobic bile acids to less toxic hydrophilic bile acids.
Hydrophilic acids.
And we don't generally use or recommend UDCA, but in cholestatic phase where the itching is there is no harm in giving. It's not going to do any harm. Okay, in AIM, the treatment is always a supportive treatment. What important thing you should advise as a part of the treatment? Usually as a postgraduate
Hepatitis B.
you advise. The two important things is always the diet and provide hepatotoxic drugs.
Okay.
The chronology of events she must have recovered, but one thing she has landed in a hospital. She has been given the native treatment. That may be the reason for the long jaundice in this child. That you should always advise not to take any native medications because I think you can even tell them we are not going to give specific treatment for viral hepatitis. What are given is always a supportive treatment. And the diet is very important. When to look for your danger signs among the following history, whatever you are given. Suppose a patient is admitted in the ward. What thing you'll ask the mother or when you're making rounds? When you be very cautious based on the history.
When there is going to be persistent vomiting.
Yes, very good. Persistent vomiting, persistent anorexia.
Constipation history.
Very good.
Sleep disturbance pattern. No?
Very good. These important things. Yes, you have to always be very alert, and during rounds, you also look for the deepening of jaundice. And suppose you have a palpable liver of 4 centimeter or 5 centimeter. Next day, when you're just palpating liver, it is 1 centimeter. That is also an ominous sign clinically. So, a rapidly shrinking liver and a deepening jaundice and presence of an ecchymotic patch indicates the child is slipping into acute liver failure. So, the history of vomiting is very important. Okay, proceed.
Now this
Niveda,
you should.
Niveda, one of the judges has asked that if the patient has improved, why have they come to the hospital if the patient has started improving?
Is itching and persisted, ma'am, and the yellowish discoloration of eyes was present, ma'am.
So now, what is the? That's why they have come. Now, usually, what is the cause of hepatitis A infection? Usual cause, for a child who is less than 6 years and an older child or an adult. This is a 12 years old child.
Yes, ma'am.
Old patient. So, for example, if a child is less than 6 years, a younger child, what is the usual cause? And for older child and adult, usual cause of hepatitis A.
Ma'am, they will recover.
Who will recover earlier?
Child will recover earlier, no?
Yeah, younger one, less than 6 years. Usually, they may remain asymptomatic, and only 1/3 of them remain symptomatic. And usually 1 to 2 weeks is the cause of illness, and they recover. Whereas in an older child or an adult, the cause of illness can be for usual cause of illness. In an older child, this is 1 to 2 weeks, we said. But if this is an older child, can it be expected, or it has to become all right by 1 or 2 weeks? Or older children can take up to 1 month, 4 weeks for them to recover also. So it was not unusual. But what the patient did now, as Sumati Madam rightly pointed out, left alone, this is a self-limiting illness. There is no need for treatment. Child, by taking rest and all that, child would have recovered completely by 1 or 2 weeks. But what did the patient go and do? Patient went and took
native treatment.
Native medication. So native medication, when taken, and they are not kept. What are the other types of native medication which people in and around Chennai usually follow? We should be aware.
Negium Legium, Suranam.
Where do they go?
Keelanelli.
Madam is asking, where do
They
they
will go for Balaja.
Any place in Chennai,
Balaja.
they used to land up.
Star Theatre தெரியுமா உனக்கு?
சென்னை வாலாஜா விடுங்க, சென்னையில சொல்லுங்க.
Yeah.
They go to triplicate. Now, which is dangerous? Oral medications or local applications? What is dangerous? What are the other native treatment they usually do when the children get hepatitis or jaundice? Have you seen them branding them? Branding, chudu vepa.
Yes.
They keep branding and they take oral medications. The oral medications may contain steroids sometimes, usually, and it might prolong your shedding of the virus. And oral medications, when they take, the duration, the course of illness becomes very much altered. It becomes more serious and very much altered. So this patient has taken oral medication, and this branding, what problem it can produce? Have you seen them being branded? That is what they will do. That produces secondary infection. Child can also go in for sepsis. These are the problems. And child from acute viral hepatitis, it will proceed to probably toxic hepatitis, and things might end. And it might rapidly progress on to even acute liver failure. Okay. That is what these are the symptoms when to suspect acute liver failure only. Sumati madam was asking you, child becomes more irritable or either becomes sleepy, there is sleep disturbances, or their abdominal distension starts appearing, liver starts disappearing. These are some of the early signs that the child is going for fulminant hepatitis or acute liver failure, and you're always observing whether the child is going in for hepatic encephalopathy also. Okay, this child has taken native medications, but and after that what happened? Child started getting itching. Child had itching throughout. Okay, proceed. Next slide.
Ilamadi, one question for you. Lakshmi madam said that in children it may be asymptomatic, 2/3 of the cases. So if you take around 10-year-old children, 100 10-year-old children, how many you think would have been exposed to hepatitis A? Roughly, by the time the child becomes 10 years of age, how many of them would have been exposed to hepatitis A? How common is it?
Most common, ma'am, around 80 to 90%.
Okay, not 80, around 50%. So by 10 years, they say at least 50% would have been exposed to hepatitis A. They will not be, even if they have not had even a single episode of jaundice in the past, at least 50% would have been exposed to hepatitis A.
Okay.
This has an implication in the vaccination policy. I'll ask you a question later about that.
So most infections are clinical in children because they don't know they had even hepatitis A in the past. That's a very important, especially the low socioeconomic status. That's a boon, especially because when any children with chronic liver disease coming from a low socioeconomic status, by the time even the Wilson disease, by the time they reach 10 years, they have acquired the infection in the early childhood. Suppose the same
compared to previous era, they are saying now, compared to previous era, now the age at onset of this hepatitis A is increasing. The epidemiology of the disease is changing. So why is it so? Any idea? Why is the epidemiology changing?
Because of the vaccine.
Because of the vaccine
is not available in national schedule.
Socioeconomic status, ma'am.
Improving.
Better hygiene practices.
Yeah, hygiene hypothesis. Okay. So that is the
reason because of the better hygiene.
Okay, very good. Now all of us are talking as though hepatitis A alone is the only cause of hepatitis and jaundice. Since this child is not behaving normally, what are the other viruses which can cause hepatitis? Ansil, can you answer? Or anybody who knows it? What are the other hepatotrophic viruses and other non-hepatotrophic viruses which can produce fever with jaundice, which is not proceeding in the usual course?
Hepatitis B.
Hepatotrophic viruses or hepatitis B.
Very good.
Hepatitis B, ma'am.
Hepatitis
yeah. D and E.
Okay.
Non-hepatotrophic viruses.
Yes. What are the other non-hepatotrophic viruses?
Measles, mumps, rubella, cytomegalovirus.
Okay. No, measles, mumps, rubella illa. Cytomegalovirus, yes.
Epstein-Barr virus.
EBV, yes. Herpes. These are the 3 other viruses. Yes. And can you tell me some other bystander hepatitis? Nama solluvom. And the disease where, but it also affects the liver. We call that as bystander hepatitis. Can you give me some names of these bystander hepatitis?
Typhoid, ma'am.
Very good, excellent.
Leptospirosis.
Excellent.
Malaria.
Very good. One more infection, scrub.
Kalasa.
No Kalasa. Malaria. Don't correct. You are going. Okay. So now,
Suspect, yeah.
bystander hepatitis, as rightly said by all of you, are scrub. It can be scrub. It can be lepto. It can be malaria. It can be enteric fever. So hepatotrophic viruses and non-hepatotrophic. Can it be any of these three? Admari, can you think of it by history wise? Or you want to go for the examination and then finally decide?
Any other history, madam is telling a clue.
You want to ask me, for example, can it be a case of enteric fever? I told you initially itself
Toxic appearance of the child is not so toxic, ma'am.
Child is not
Toxic, ma'am. In case of enteric fever, child will be toxic.
uncoated, dehydrated, and jaundice is usually very
Anectic
hepatitis. We call it as anectic hepatitis. Okay, very good. This is apart this condition. Any other condition where you know in anectic hepatitis, which can be a life-threatening condition?
Yes.
Yes.
During
Especially
Ray syndrome.
very good. Excellent, very good. Ray syndrome. It is life-threatening. Very good. It's a one condition where there is no ictus, but enzymes are enormously elevated. Okay. Okay, proceed.
don't forget dengue infection, because these children can have jaundice. Most of them it is anectic, and especially when they come with shock, OTPT may be very sky high. Always think three important conditions when you have very high OTPT in thousands. One is always a viral hepatitis, acute viral hepatitis. Number two is always due to shock or ischemic hepatitis. Number three is always the toxins or the drug-induced. These three important conditions will have very high OTPT. And as madam said, myalgia will be seen in leptospirosis and also dengue fever. Okay, so then when you do OTPT, rescue OT may be also elevated in dengue fever as well as in leptospirosis. These are some important clues.
Okay. Since Sumati madam has raised the point about leptospirosis, what are the clinical? What are the clinical presentations on what symptomatology they might come to you, and what two clinical findings you would like to see in them?
fever, ma'am.
Okay.
And conjunctival suffusion can occur, ma'am.
Very good. Conjunctival, but we rarely see. Can you differentiate between the conjunctival suffusion and leptospirosis and measles?
Not. It will be bulbar involvement in case of leptospirosis, ma'am.
Very good.
And palpebral conjunctival involvement in case of measles.
Okay, very good. Any other finding? Which season leptospirosis is very common?
During rainy season.
Yeah. Nalla monsoon la wading through water, walking barefoot in water, wading through water, child can present with fever, jaundice, and renal manifestations. And as I told you previously, it's usually long duration fever, more than 10 days fever. Child is also having jaundice for the past 2 weeks. It is not an acute illness. It's usually a long drawn fever, and you may have evidence of bleeding or other liver synthetic dysfunctions you may have in case of leptospirosis. Okay.
The sir has asked, when do you suspect hepatitis B?
Hepatitis B. What history you would like to ask for hepatitis B?
Any transfusion.
Transfusion.
Tattooing or IV drug use.
Okay, IV drug uses, any needle stick injury, okay, any injections and all that. Transfusion, 90% transfusion hepatitis is hepatitis B or C. Ilamadi? For example,
C, ma'am.
Very good, excellent. 90% of your transfusion hepatitis is C. It is not B. Which is dangerous among the two, B or C? You like to have? Sorry, I know I don't want you to have. If I want to have, hepatitis B or hepatitis C, which is dangerous?
C, ma'am.
Hepatitis C is dangerous.
No, hepatitis C is not dangerous. Hepatitis B is more dangerous, more serious, difficult to treat than hepatitis C. Okay?
Okay.
2 points I want to reiterate. Hepatitis B is more dangerous, and transfusion-related hepatitis is mostly due to hepatitis C. And PRC sir has rightly pointed out, apart from your history, you should also history of arthralgia, skin rashes. They are more common in children with hepatitis B. Okay? Yes.
So don't forget thalassemia, hemophiliacs in pediatrics. Okay, those patients with chronic kidney disease who undergo hemodialysis, these are children who are very prone. And we have vaccine for B. So as I rightly said, those who are not vaccinated for B can have acute hepatitis B. And you have to get a clue for rashes. They can have urticaria, they can have leukocytoclastic vasculitis in B, arthralgia. And in C, it is always anectric hepatitis. 90% it is anectric. B can be ectric or anectric. So always get a clinical clue and the history, your background history. Okay, and you see for C, you don't have any vaccine, unlike B.
Okay.
Okay. Next slide. Yes. No history of?
No history of abnormal behavior, decreased scholastic performance, or abnormal movements.
Why did you ask this history?
To rule out common metabolic disorder, Wilson's disease, ma'am.
Okay. Wilson's usually, the child is 12 years. What type of Wilson's usually manifest at that point of time? Hepatic Wilson's or neuro Wilson's?
Neuropsychiatric, neuro Wilson will manifest, ma'am.
What are the various manifestations Wilson's can manifest? One, you said neurological Wilson's. Younger age group, usually hepatic Wilson's, then hepatic plus neuro. Okay. Otherwise, what are the various manifestations Wilson's? Wilson's is one disease, metabolic liver disease, easily treatable. So we'll have to make it out. We'll have to always rule out Wilson's. What are the various manifestations?
You can have liver manifestations, ma'am.
Like anything. What you say first tell the liver, then you can tell the extrahepatic.
Okay, ma'am. They can present as acute hepatitis also, ma'am.
You can do acute hepatitis. Yes, then.
And they can have a asymptomatic hepatosplenomegaly.
Very good. Excellent. Next.
Then they will have elevated, unexplained elevation of
The clinical spectrum. You said acute hepatitis, acute liver failure. They can present subacute liver failure,
Chronic hepatitis,
chronic hepatitis,
Fulminant
cirrhosis.
compensated versus decom. These are the hepatic phenotype. And as madam said, neurophenotype.
Oh.
The child just dropping in school performance, backwardness in school, change in handwriting, then extracurricular involvement, beating the other children, neuropsychiatric manifestations, getting beaten up at house because of frequent dropping of things due to the extrapyramidal, always keep Wilson disease. They can even present dysphagia.
Very good.
It is a neuro, but don't forget the other system involved in Wilson disease because they can any other department or even for
other departments it can go. Any ideas?
Ophthalmological.
why do they go to ophthalmology? Because why?
cataract,
Cataract and
Interfere with vision.
vision.
What's the difference between the Wilson cataract and other cataract?
It won't affect vision, ma'am.
Usually they don't affect the vision only for the cosmetic reasons. And so they can go to ophthalmology, they can go to hematology for
Dermatological manifestation.
hemolytic anemia, just for anemia. They can go to endocrinologist because of delayed secondary sexual characters, hypoparathyroidism. They can go to orthopedician for your renal manifestation, rickets, fractures, bone pain. Don't forget all those things. So these
renal problem. What
involvement can be due to liver or due to renal, because both organs can be affected in Wilson's disease. They can go to neurologist apart from that, difficulty in getting up, proximal muscle weakness, myopathy, very rare even seizures. So these are some of the other system involvement in Wilson disease. Okay.
What is the renal manifestation, Nilamati?
Proximal tubular dysfunction.
Very good.
Very good. Excellent. Excellent. Very good. Okay. Proceed. Proceed. Now we have asked for next question you have asked is no history of chronic drug intake.
Chronic drug intake. No.
What drug intake you asked which can produce hepatitis? Commonly used drugs which can produce hepatitis.
ATT.
Very good. ATT.
Among the ATTs, which are all the hepatotoxic ATTs?
Isoniazid, rifampicin,
Then?
pyrazinamide.
Very good. All three are hepatotoxic.
Same drugs. Very good. When to suspect drug-induced acute hepatitis clinically? Any clue? So then we step drug intake. The child can present fever. They can have arthralgia, rashes, and sometimes a peripheral eosinophilia can give a clue. So,
What do you call that? Eosinophilia, systemic symptoms, rash, drug. What is DRESS? Dress.
Drug-induced
Yes.
reactive eosinophilic
Drug-induced eosinophilia with systemic symptoms.
systemic symptoms.
Dress. That is what we call it as dress. DRESS. Okay. Now, DILI use the terminology.
Drug-induced liver.
It is commonly used in. When do you call it as, for example, liver enzymes elevate aganuma?
More than thousands, ma'am. High elevation.
No. All children need not have necessarily more than 20. When you call this child is having drug-induced liver injury, how much is the liver enzymes elevated? OTPT we take. Among the OT and PT, which is more important, PT or OT?
PT,
PT,
ma'am.
ma'am.
PT, ma'am.
PT is liver specific. OT is also okay. How much liver? How much you want that to be elevated? 2 times an hour.
More than 5 times elevation, ma'am.
More than 10 times of the normal, ma'am.
5, 10, 15, 20.
10, ma'am. 10.
10. Okay, it's not like that. No, anything more than 2 times the upper limit of transaminases, elevated liver enzymes சொல்றோம். அதை நம்ம classify பண்றோம். Mild, moderate, severe elevation of liver enzymes. For example, less than 3 times the normal na mild. 3 or 5 to 20 times the normal na moderate சொல்றோம். More than 20 times the normal, then we call it a severe transaminases, a severe elevation of liver enzymes. More than 2 times the upper limit of normal itself elevated liver enzymes. சரியாமா? Okay, yes.
Don't forget sodium valproate we use for seizures in children. Okay, sodium valproate always is one of the hepatotoxic drugs.
Any drug, important, commonly used drug which produces liver injury?
Paracetamol.
Paracetamol, ma'am.
If
they present with even acute liver failure apart from acute hepatitis. Okay, so be very cautious, get into the history, the dosage.
Okay, what is the highest dose, maximum dose of paracetamol you can give? ஒரு நாளைக்கு ஒரு பாப்பாக்கு நீங்க எழுதுறீங்கன்னா எவ்வளவு எழுதுவீங்க? மேக்ஸிமம் எவ்வளவு எழுதுவீங்க? Per dose எவ்வளவு எழுதுவீங்க?
15 mg per kg per dose.
How many doses?
60 mg per day, ma'am.
That is the maximum dose you want to give. Okay, 60 milligram per kilogram you want to give. That is the maximum. Okay. Okay, yes, yes, right. One thing, if you are supposed to become the health minister, நீங்க paracetamol பத்தி ஏதாவது ரெகுலேட் பண்ண விரும்புறீங்களா? Anything you want to regulate about paracetamol? ஒரு health minister ஆகுறீங்களா, ஒரு IAS officer, health secretary ஆகுறீங்கன்னா, first thing I would like to do is bring
Over the counter,
ma'am.
commonly used drug which is being abused and misused, because it comes in various combinations. 1 ml is equal to 100 milligrams, 5 ml is equal to 125 milligrams, 5 ml is equal to 120 milligrams, 5 ml is equal to 250 milligrams, 200 milligrams, நிறைய combinations இருக்கு. So always whenever you prescribe paracetamol, be very careful, see your preparation and then give the drug, right? Okay, so paracetamol, antituberculous drugs, and as Sumati madam rightly pointed out, anti-epileptics, especially your sodium valproate. These are common drugs which we use, which can produce acute liver injury. Okay, yes, then you have asked for history of... Next, proceed.
No history of rash and joint swelling, ma'am.
Where did you ask for this?
Any autoimmune hepatitis?
Oh, அதுக்காக கேட்டீங்க. hepatitis B ka autoimmune hepatitis நம்ம பேச வரல, நீயா நுழையற. Okay, autoimmune hepatitis, what are the criteria for autoimmune hepatitis? Exam la kuda, if you know about autoimmune hepatitis, come for it. Okay, no problem. But even you should tell me what are the criteria for autoimmune hepatitis?
Female.
It will be female predominant.
Not necessary. Okay, vachiko. Okay,
Then there will be response to corticosteroid and
criteria.
Hypergamma
Yes, very good. One point. Yes.
Presence of antibodies.
there are autoantibodies
Like
LKM antibody, ANA.
இல்ல, anti-nuclear antibody more than எவ்வளவு? Once you commit for autoimmune hepatitis, you should know everything. Anti-nuclear antibody is more than
120, ma'am.
Okay, அப்புறம் asthma என்னமா? Asthma.
Smooth muscle
antibody.
Body at least 1:40 இருக்கணும். Okay. More important is எல்லாத்தையும் விட what is the most important parameter for autoimmune hepatitis? You said something. Biopsy we don't, nowadays we don't even require for diagnosing autoimmune hepatitis. What is the most important parameter? You should
immunoglobulin level, ma'am.
Exclusion of other diseases diagnosis.
That is very important.
All other diseases before committing for autoimmune diseases. Hypergammaglobulin, elevated ANA, anti-smooth muscle antibodies, இதெல்லாம் இருந்தாலும் exclusion of other disease with a similar presentation. Only then you can call it as autoimmune hepatitis. But actually, awareness has increased and we have started seeing more and more cases of it. Okay, history of rash and joint swelling, PRCs இருக்குற மாதிரி hepatitis B ல நீங்க பாப்பீங்க. And for autoimmune hepatitis also you can look for. Okay, next, go. Yes, proceed.
No history of abdominal distension or leg swelling.
So you are ruling out decompensation. Okay.
No history of reduced urine output.
Okay.
No history of difficulty in breathing. No.
Okay, proceed. Next slide.
No history of vomiting of blood or passage of black, foul smelling and tarry stools and other bleeding manifestations.
Okay, so there is no decompensation, no GI bleed in this child at all. Okay, yes.
No history of constipation.
Okay.
No history of altered sensorium and excessive sleepiness.
Okay, idella encephalopathy. Okay, yes.
This should go no. Any acute hepatitis go for that. I know this red flag signs at the onset. Then bringing your abdominal distance, they can come down on the list. Altered sensorium bleeding, diathesis, excessive sleepiness is a manifestation of AL. The decompensation, your very cell bleed, whatever can be due to underlying chronic liver disease. Symptoms CLD can present for the first time as acute hepatitis, especially Wilson, not autoimmune. But a child can have underlying chronic liver disease. Okay, so all this history can be down, but your sensorium, sleepiness, bleeding, diathesis due to ecchymosis, your coagulopathy can be even higher. Okay, very good. Yeah.
Okay.
நீங்க ஒரு பிஜியா உட்கார்ந்துருக்கீங்கப்பா, சடன் ஆன்செட் ப்ளீடிங், அப்பர் ஜிஐ ப்ளீடோட ஒரு சைல்டு வருது. இமீடியட் மேனேஜ்மெண்ட் என்ன? வாட் வில் யூ டூ இமீடியட்லி ஆஸ் அ ஈரும் பிஜி? Steps in management of acute upper GI bleed.
Yeah,
Immunization, ma'am.
ABC, ma'am.
AP may always you take some time immediately ABC. Yes, very good. Then 2 steps அடுத்து ரெண்டே நமக்கு வேற என்ன சொல்லுவீங்க?
Pharmacological therapy.
Right?
Vasoconstrict, telepressin, vasopressin.
ஒரே நிமிஷம். Who said terlipressin and vasopressin? Iramadi, how many times you have used terlipressin and vasopressin? In ICH, I have not used even once terlipressin and vasopressin. Upper GI bleed, இதெல்லாம் adult teaching. நம்ம வந்து இதெல்லாம் யூஸே படுத்துறதே கிடையாது. What do we use? We never use vasopressin or terlipressin. We have never used probably for 25 years or 30 years now. Maybe long back, we never used because we have got other drugs. Management of upper GI bleed, what are the other drugs we give? Any upper GI bleed, not necessarily portal hypertension, chumma or upper GI bleed, what are the steps which we will do immediately? ABC paathenga, very good, excellent. Then
secure IV access, whether the patient is going to be in shock or not.
Yeah, shock correct pandrenga, saline shock in a fluid which correct pandrenga. Okay, you corrected shock, yes, then
NG
H2 blockers, ma'am.
H2 blockers, இப்போ நீங்க என்ன யூஸ் பண்றீங்க nowadays? What do you use? Homas யூஸ் பண்றீங்களா? Pantoprazole யூஸ் பண்றீங்களா? என்ன யூஸ் பண்றீங்க? What are you using?
Omeprazole.
Homas IV available ஆமா? ஒரு upper GI bleed நிறைய வருது, அப்ப வந்து yes, IV
Panto, ma'am.
Pantoprazole is there. Okay, then you will try to find out the etiology. You do a blood grouping and cross matching, NGT aspiration if necessary, IV Pantocid you give. And then you try to find out the etiology and then manage according. Okay, go ahead. But இதெல்லாம் standard, we always ask, how do you manage?
Yes.
Yes.
Step by step management.
Step by step management, all of you should be aware of because we are going to treat them in the room. Yes, next, proceed.
Past history, ma'am.
Okay, yes. This all similar. இதெல்லாம் நம்ம ஏற்கனவே கேட்டோம். Yes, proceed. Next, antenatal.
Antenatal history, booked and immunized, iron and folic acid tablets taken. All 3 trimesters were uneventful. No history of jaundice and pruritus in mother.
Oh, very good.
And natal history.
Getting a no history of jaundice in mother.
Hepatitis E is hepatitis E can occur in during pregnancy, which can land up in.
No, for this child.
And
is now 12 years old.
Ma'am.
You mean to say mother is pregnant, jaundice and pruritus is a mother, there is a high fetal loss if it is due to E. But for this child at 12 years, what is the importance? No,
intrahepatic cholestasis
is a mother.
Intrahepatic cholestasis of pregnancy, progressive familial intrahepatic cholestasis.
Yeah, not for ICP, you can think of PFIC, which can run in families. Okay, progressive familial intrahepatic cholestasis, because at this age of 12 years, but usually they even manifest earlier, depending upon the type of your PFIC. Okay.
PFIC hallmark clinical manifestation. அதை பார்த்தோனே இது PFIC ஒரு 1 year old child வருது இல்ல 3 years hallmark of
normal.
Hallmark of PFIC என்னமா? Just yes, very good. Pruritus and scratch.
Younger age of onset usually present. Okay. They can even present with diarrhea, abdominal pain if it's a type 1 PFIC. Okay. So in
Okay.
this case, what is the importance we should analyze? Not for us, a general statement. No, it's a jaundice and pruritus and mother. Okay.
Mother, why you made a statement? Period statement. Hepatitis E in mothers, pregnant mothers. That's a problem in hepatitis E in pregnant mothers. Pruritus is a problem.
Fulminant hepatitis.
Fetal loss.
For example,
It's a late stage. That is very important. Yeah.
okay, it is 20% of them can also go in for acute liver failure, hepatitis E. But what is the percentage of acute liver failure in hepatitis E?
What percentage?
Less than 1%.
Very good. Less than 1%.
Yeah.
Less than 1% going for acute liver failure. Whereas hepatitis E, 20% can go. They can go. But other than answer jaundice and pruritus, any other?
Acute fatty liver of pregnancy.
Pruritus, fatty liver, it's only an ultrasound diagnosis or hepatomegaly. Anything else? What do you want to highlight?
Anything? It's very important history. Why during pregnancy, especially in children, especially young infant, they're presenting.
Fever, rashes, fever history, ma'am, along with fever.
We always assert
rashes.
that no, even like A, E, B and C during last trimester can be transmitted through the placenta. The most common presentation is always a fecal or transmission. But viremic phase, they can be even transmitted. Similarly, pruritus, the mother can give a flu for your any L-shot deficiency in the metabolic liver disease. Infant can present with long chain nasal dehydrogenase deficiency and inherited syndromes of familial intrahepatic cholestasis. Okay. So always keep, am I dealing with some infection or inherited conditions? That is very important when you're getting the maternal history. Okay. Good.
If avoid பண்ணிருந்தா நிறைய தலைவலி உனக்கு முடிஞ்சிடும். Pruritus.
Committed, you should know how to come out.
Undergrad, postgraduate, which path you want to let, you should go in that path. This is not a very important history. Unnecessarily, it has made you நிறைய questions கேட்க வச்சிருச்சு. Okay, go ahead.
Okay.
But no problem. It's only a teaching session, no problem. Okay. Yes.
Natal history.
More important than this, if for example, in the mother, hepatitis B positive, HbA1c positive mother, that as a pediatrician, what will you do as soon as the child is born? Even if you don't know anything about PFIC, I am not at all bothered. But if you don't know this you should know this. Mother is HbA1c positive. What will you do? What will you do about the child? What breastfeeding advice you will do? Will you isolate the child? What 2 things you'll have to do necessarily do immediately?
Hepatitis B immunoglobulin concentration.
0.5 ml. Okay, சரி. அடுத்து போட்டேங்க. அடுத்து என்ன பண்ணுவீங்க? உடனே என்ன பண்ணுவீங்க? Hepatitis B immunoglobulin, excellent.
Hep B vaccine,
ma'am.
You should give the vaccine within how many hours of birth?
12 hours.
12 hours, ma'am.
So hepatitis B vaccine, hepatitis B immunoglobulin, then you should follow it up with அடுத்து regular immunization continue பண்ணுவீங்களா?
Yes, ma'am.
6 weeks, 10 weeks, 14 weeks, you are again going to continue the regular vaccination. Okay, that's good. What advice you give regarding breastfeeding? Hepatitis B virus is transmitted through the breast milk. Yes, sir.
No, ma'am.
No, ma'am, but in cracked nipples, it may transmit, ma'am. So breastfeeding can be started after immunoglobulin.
So what precautions or what advice you have to do? I know, read something about a maternal transmission, maternal child transmission. Suppose a mother has got a very high viral load, when to treat the mother, you have to check the EH status of the mother as well, and what important drugs you can give during pregnancy. So if a mother has got a very high viral load, then you have to continue at least 100 days after delivery. Okay, suppose a mother has got a cracked nipple, bleeding, you should be very cautious. Okay.
We don't give. Okay. But we don't give a blanket statement. Give breastfeeds, don't give breastfeeds. Individualize we individualize for that particular we can individualize for that particular patient. Okay. But is it transmitted through breast milk or not? You said no. HIV is transmitted through breast milk. Hepatitis B is transmitted through the breast milk. But still, as per our national policy, you, in spite of whether you're HIV positive or HbA1c positive, You continue breastfeeding, but again, as Sumati Madam rightly said, you also take certain precautions. Okay? Yes. Postnatal history, yes.
Breastfed within an hour of birth. No
Yes.
issue of neonatal jaundice, umbilical vein catheterization or umbilical sepsis. No history of exchange transfusions or neonatal convulsions.
Okay, yes.
In developmental history,
Anything abnormal? No. No. Child has been under developmentally normal child. Okay. Proceed. The nutritional history, yes.
nutrition history, consumes mixed diet, consumes non-vegetarian diet 2 days a week, and 2 eggs per week. By
So,
24
getting adequate calories and very little deficit. Okay, very good. Yes.
Only one important thing in acute hepatitis, always tell the mother whatever it is to give protein of animal, avoid protein of animal origin, preferably protein of vegetable origin is good. Why?
Ma'am, less
It is
ammonia.
let amino
It is ammoniagenic, more ammoniagenic. Okay, the normal recommended fat should be given. Protein should be of vegetable origin. Okay, yes, good. Don't tell the mother to give only. They always put the child on a bland diet, pathium. That itself will precipitate your hypoproteinemia, and the liver will take a longer time for regeneration. You need adequate protein for the liver to undergo regeneration and come out of the illnesses. Okay, very good. Proceed.
Proceed.
Family history, firstborn of third degree consanguineous marriage. His younger sibling also had complaints of yellowish discoloration of eyes associated with fever and high colored urine for 1 week, for which he was treated at a government hospital and was taking UDCA tablets for 2 weeks, after which his complaints subsided.
So it's likely to be what?
Yes. Is there any clue?
Viral
Diagnosis.
Viral hepatitis?
Yes.
A, ma'am.
A. Likely to be A. Can it occur in family members at an interval of 1 or 2 weeks?
Yes, ma'am.
Yes, ma'am.
Really, we say it's very highly infective. Hepatitis A is highly infective. In fact, we can tell highly contagious. That terminology also can be used. And fecal-oral transmission, community transmission due to the same shared food. Okay. Okay. So this child had hepatitis A but recovered. He was a younger sibling. Okay. He didn't take any native treatment, right?
No, ma'am.
So child has recovered well. Okay. Yes. Yes. 2 weeks. Yes. Proceed.
2 weeks after.
What is the incubation period of hepatitis A?
15 to 20 days, ma'am.
Hepatitis E?
20 to 60 days, ma'am.
Viral shedding, how long does it take place in hepatitis A? For example, after the child becomes manifest symptoms also, how long does the viral shedding continue? That's why others are getting infected.
1 week, ma'am.
No, you can
2 to 3 weeks.
can be there, RNA is directed even up to 1 month, they say.
Yes.
So it continues for a long period. Viral shedding of hepatitis, though the illness is mild, shedding of the virus, that's why it immediately it spreads to others in the same family. Okay. Proceed.
Hygiene is very important. Advising on the health, like how to prevent. Prevention aspects very important. Yes, proceed.
Proceed, ma'am.
Socioeconomic history, father daily wage worker, mother homemaker, studied up to 10th standard, family of 4 members, lives in semi-paka house, 2 rooms, separate kitchen and toilet, adequate ventilation present, drinks boiled tap water, according to...
Boiled tap water, unlikely. நீ வந்து இது தினமும் எல்லா தண்ணியும் அவங்க கொதிக்க வச்சு குடிச்சாங்களா? நிஜமாவே இது உண்மையா? Is it really true? They would have got canned water and would have drank. That's what is happening in Chennai. But they are using boiled water, very unusual. Okay, yes. But still they got hepatitis.
Yes.
Okay. Yes.
12 years old male child, firstborn of third degree consanguineous marriage, admitted with complaints of yellowish discoloration of eyes, high colored urine and pale colored stools, itching for the past 2 months, resolving at the time of admission, initially associated with fever, abdominal pain and vomiting, with past history of native treatment and oral medications taken for the above complaints, positive family history of similar complaints in his elder sibling 2 weeks before the onset of our patient's complaints. Probably this is a case of acute hepatitis of infectious etiology.
Okay.
Proceed.
Proceed.
General examination. On examination, child is conscious, oriented, and comfortable at rest, afebrile, Icterus noted at conjunctiva, soft palate, no pallor, no cyanosis, no clubbing, no lymphadenopathy, no pedal edema. Scratch marks noted over legs and abdomen. SMR staging 2.
Very good. You have done the SMR staging. Excellent. Supposing this child has had pallor, jaundice, pallor, fever. What will you think in terms of?
Malaria, ma'am.
Malaria, ma'am.
Okay, very good. Okay, yes.
Head to toe examination. No cataract, bite out spots, KF rings, icterus present, no
parotid. KF ring. KF ring naked eye pathingla eppadi pathinga naked eye examination? You mean?
No. Only in slit lamp examination it can be seen.
Okay, all cases of Wilson's, do they have KF ring?
No, ma'am.
In the stage of Wilson's, the KF ring is more common.
Neurological.
Less than 3 years KF ring paaka mudiyuma? Less than 3 years vandirukuma. KF ring can
no, ma'am.
Not be. Usually, what age group KF ring is practicing?
12 to 15
Above
years.
Neuro Wilson's, how many percentage of cases will have KF ring? Usually, older children.
97. 97, ma'am.
Neuro Wilson's, they will have KF ring. Okay. Can you give me some other causes for KF ring? Only Wilson's, or do we have other causes? Where are
Chronic cholestatic conditions can also cause KF-like rings, ma'am.
Okay. How do you identify? Naked eye, then what do you do?
Slit lamp examination.
Okay. Usually, when you are looking at the naked eye, which portion? Usually, where does it appear first?
Superior.
Superior limbus, then
inferior and superior.
Medial and lateral, ma'am.
Then it becomes a lateral. Usually, histology question. Enga poi deposit on the copper.
Basement membrane, ma'am.
That's an MCQ, so all of you are very good at it. Very good. Okay. So bite or spot, why did you look for?
Acute vitamin A deficiency.
Acute.
Sorry, ma'am. Vitamin A deficiency.
Acute vitamin A deficiency produce acute or?
No, ma'am. Vitamin A deficiency.
Vitamin A deficiency of prolonged duration. Bite or spot. Supposing you treat the child with lots and lots of vitamin, adequate dose of vitamin A. Does the bite or spot disappear?
No, ma'am.
No, ma'am.
I think Nayanthara Vijay Sethupathi நான் நிறைய தடவை பார்த்திருக்கேன். அவங்க ரெண்டு பேர்ல யாருக்கு I don't remember, they have the bite or spot. You remember. However, நீங்க எவ்வளவு விட்டமின் A கொடுத்தாலும் bite or spot will not disappear. That will not disappear. Bite or spot எங்க பாத்தீங்க? Where did you look for bite or spot?
Lateral aspect of the conjunctiva.
Lateral aspect you look for the bite or spot. How do you treat vitamin A deficiency?
Ma'am, less than 6 years, we can give a.
இது வந்து older examples உனக்கு வந்தாங்கன்னு வெச்சுக்கோங்க. Definitely இதெல்லாம் ரொம்ப important. இல்லாட்டாலும் you should know about treatment of vitamin A deficiency. WHO classification of vitamin A deficiency and treatment of vitamin A deficiency. Yes. Vitamin
less than 6 months, 50,000 units, ma'am.
Okay, very good.
6 months to 1 year, 1 lakh units, and more than 1 year, 2 lakhs units, ma'am.
Excellent, Yadavadi.
How
Excellent.
many doses?
How many doses?
3 doses, ma'am.
Okay. Can you tell me some common vegetable sources? Sorry, vegetable சொல்லிடுவேன். Okay. Can you tell me, supposing ஒரு nurse கொடுக்க சொல்லிருக்கீங்க, நீங்க விட்டமின் A கொடுக்க சொல்லிட்டீங்க, அவங்க வந்து ராங்கா டோஸ் கொஞ்சம் ஹையா கொடுத்துட்டாங்க. What are the features of acute hypervitaminosis A? Very, very common in our immunization OP ல. நம்ம அங்க வச்சுதான் விட்டமின் A கொடுப்போம். இன்ஃபேக்ட் we have a separate spoon for vitamin A, ஒரு small 2 ml spoon இருக்கும். அதுல கொடுக்காம sometimes நிறைய கொடுத்துட்டீங்கன்னா what happens? Acute
vomiting.
Due to எந்த ட்ரக் கொடுத்தாலும் வாமிட்டிங் வரும்ல, அது வேற விஷயம். Acute hypervitaminosis usually due to
Madam is giving you a clue.
Keratonemia.
Headache, convulsions எல்லாம் வரும்.
என்ன?
Pseudotumor cerebral.
Very good.
Acute கொஞ்சம் இதாச்சு. But chronic, for example, ஒரு enthusiastic, ஒரு educated mother என்ன பண்ணும், என் பிள்ளை ரொம்ப weight கம்மியா இருக்கு, தினம் விட்டமின் A கொடுத்துட்டே இருக்கும். Sudden seas அந்த காலத்துல எல்லாம் விக்கும். So they keep on giving those capsules or tablets of vitamin A. Chronic hypervitaminosis, how does it manifest?
How do you diagnose based on some investigation?
How does it produce? Okay, that you can take it as a homework. அது நாங்க 5H அப்படிலாம் சொல்லி தருவோம். Hyperostosis, அது okay. Hyperemesis.
Caffeine disease. Okay, hypervitamin, chronic
Chronic
hypervitamin.
hypervitamin. Okay.
Very good. Osteoarthritis of the bone. So cavering usually you don't see in other conditions, but as madam said, non-Wilson cavering can be seen in any chronic cholestasis. And white dot spot in acute hepatitis A is unlikely unless the child is already malnourished. That is chronic liver disease, they can have vitamin A deficiency because the storage of vitamin A is the eto cells of the liver and the storage time is half-life around 6 months. So chronic liver disease is more common, but don't forget in children always look for your all vitamin deficiency, especially in from low socioeconomic status. Okay.
மேடம் கேட்டிருக்காங்க விட்டமின் கே ஏதாவது பாப்பீங்களா கண்ணுல விட்டமின் கே டெஃபிஷியன்சி இருந்துச்சுன்னா ஏதாவது பாப்பீங்களா
Subconjunctive.
Very good. You can also look for
hemorrhage. Yes, give me the clue for the etiology.
manifestation.
Acute hepatitis.
Okay. Okay.
This infection will have subconjunctive hemorrhage and acute hepatitis.
Yes, நம்ம பேசிட்டே இருந்தோம் முதல்ல.
ஆமா.
Prolonged jaundice.
Go and refer. Given a clue. Yes.
Yes. இப்போ அதே மாதிரி நீங்க இந்த parotid enlargement, gynecomastia, palmar erythema, any number of case of chronic liver disease la this parotid enlargement la varadu. Parotid enlargement child la pathina you should think in terms of HIV rather than chronic liver disease, right? Okay, we don't see anything in chronic liver disease la adults la they might see, we don't see. The only thing which probably we would have seen is spider nevus rarely. Dilated abdominal veins, dilated veins over the upper abdominal wall. That is an important feature of CLD-GC. மற்றது நீங்க இது எதுவுமே இந்த palmar erythema, flapping tremor, hepatic encephalopathy இதெல்லாம் ரொம்ப very rare in children. சரியா? Okay, go ahead. Yes. Proceed. இந்த scratch marksக்காக நிறைய diagram எல்லாம் போட்டு I mean how do you usually treat cholestasis and this pruritus due to cholestasis? What are the various stepwise management of cholestasis, pruritus due to cholestasis? முதல்ல எடுத்த கொஞ்சம் லேசா initially mild itching, what drug you gave, then what drug you proceed to அப்படி ஏதாவது இருக்கா? Or what are all the drugs which you use for pruritus due to cholestasis?
Cholestyramine ma.
All antihistamines கொடுக்கலாமா? Yes, initially antihistamines, then you go for
any other thing
they gave in ICH. முதல்ல என்ன கொடுத்திருக்காங்க? UDCA you can go for. What are the other drugs? Then you can go for
phenobarbital,
cholestyramine or cholesterol போலாம். அடுத்து வேற என்ன drug? இன்னும் ரொம்ப persistent இந்த பேஷண்ட்ல ரொம்ப கஷ்டப்பட்டிருக்காங்க. So what are the other drugs which can also be given?
Serotonin reuptake inhibitors.
என்னப்பா? What name?
Serotonin reuptake inhibitors.
Yes.
just at this name, just put the classification to remember easily. Antihistamines and
opioid antagonist, ma'am.
Opioid antagonist, excellent. Yes. வேற ஏதாவது drug உங்களுக்கு தெரிஞ்ச drug ரெண்டு drug நீங்க சொல்லல. ரொம்ப காமனா
rifampicin.
Yes.
இன்னும் ஒரு drug very commonly used drug, ஒரு anticonvulsant நம்ம ரொம்ப காமனா யூஸ் பண்ற drug.
Carbamazepine.
Very good.
Carbamazepine கூட நிறைய skin rash வரும்.
Phenobarbital ma'am.
Got it.
Cholestyramine can be used. Ursodeoxycholic acid. Sometimes even steroids and patient is not responding, but not in acute infection. Just pruritus of chronic cholestasis of non-infectious origin. Other drugs, even ondansetron 5-HT3 antagonist. Then your opioid agonist like norepinephrine, naltrexone, because these are the steps. The pruritus, nobody knows the exact reason. Multi-pronged approach, sometimes very troublesome. You have to treat with many drugs, still not responding. But to go for your behavior diversion procedure, still not responding. Plasmapheresis is not responding. You can even go for a liver transplant. And whatever the lifestyle modification, I advise a mother to use lukewarm water, to cut the nails, to use only cotton clothing. These are the practical advice you have to give the mother. Okay, just emollients can be applied. So topical preparations, oral preparations, various classifications, and surgical diversion procedures and end-stage liver disease, especially the liver transplant.
Okay.
Pruritus.
Ansel, this child is presented with jaundice and pruritus. So if the child did not have jaundice, if the child presented only with pruritus, what are the differential diagnoses you think for pruritus in a child?
Normal skin infections, ma'am.
No, just
skin-
pruritus. See, if there's skin infection or some rash, they will show you the rash. That will be the presenting complaint. I'm asking that normal skin, the child is coming with pruritus. What all you will think, Niveda?
Atopic dermatitis.
Okay,
Any drug allergy, ma'am?
Urticaria.
okay,
Urticaria.
okay. Any other organ failure you can present with pruritus?
Renal dysfunction.
Uremia can present with
Or
pruritus.
uremia.
They can also present with pruritus. So in these conditions, you may not have a skin rash, but you may have a pruritus, and secondary to pruritus, you may have excoriations and secondary changes.
Okay. Good.
In this child, the cause of pruritus is cholestasis. Prolonged cholestasis as per the duration. Yes. Proceed.
Proceed. Anything specific?
Anything, nothing, normal. Proceed. Aduthathu vaanga.
40, yeah.
1 minute. Okay.
Yes. Anything on anthropometry, anything specific?
இதுல ஒரே ஒரு விஷயம் ஒரி பண்ணுது. தின்னஸ் போட்டேங்க. பட் ஆனா டயட் எல்லாம் செமையா கொடுத்துருக்காங்க. பேஷண்ட் வந்து ஒரு 200 கேலரிஸ் கூட டெபிசிட்டே இல்லை. எக்ஸலண்டா எக் எல்லாம் சாப்பிடுது. பட் ஆனா சைல்ட் இஸ் வெரி weight is between the 10th and 25th centile. So which must be wrong? This cannot be wrong. Weight cannot be wrong.
Yes.
So your diet history probably should read better modify pannom. Always when you give appropriate calorie, appropriate protein, child should lose weight in spite of the appropriate calorie, or your diet history is wrong. But though they should correlate, or you should be able to tell one reason for that. Okay. So thinness neenga potanala this becomes that you should verify. Okay, go to the next slide. Yes. Okay, that very you have marked in the growth chart. Excellent. Yes.
Examination of the abdomen. No?
Okay.
Inspection. Abdomen not distended. Flanks free. Umbilicus normal shape and size.
Free நீங்க சொல்லிட்டீங்கன்னா என்ன இல்ல இந்த சைல்டுக்கு?
Free fluid is not.
There's no free fluid. There is no evidence of decompensation இல்ல இந்த child. Okay, free fluid இல்ல. Okay, very good. Okay.
Umbilicus normal shape and site. All quadrants moves equally with respiration. No visible peristalsis or pulsations. Skin over the abdomen is normal except for scratch marks. No dilated veins or sinuses.
K sheet la varudhu par. No dilated veins seen over the upper abdominal wall is usually if it's a chronic liver disease. Anal no dilated veins. Okay, yes.
Hernial orifice is free. External genitalia normal. No?
Next.
Palpation.
Okay.
Not warm, not tender, no guarding, no rigidity. Liver palpable 4 centimeters below right costal margin along mid-clavicular line, soft to firm in consistency, not tender, smooth surface, rounded edge, non-pulsatile, spleen not palpable.
There is no, you cannot use the terminology soft to firm, either soft or firm, because each has its own clinical implications. The liver is soft in this setting. I always keep only acute hepatitis. Suppose a firm liver in children, even palpable, always keep a chronic liver disease. In children, you don't expect the liver to be shrunken as you see in adulthood, say a definition of clinical cirrhosis. A large liver but firm liver, always keep chronic liver disease, but don't use it and be very specific, either soft or firm. There is no terminology. I think Lakshmi madam will accept. Will accept.
எப்படி சொல்லி தருவாங்க இதனா mildly pregnant னு சொல்ற மாதிரி. அத pregnant அப்படி சொல்ல முடியாது. சாஃப்ட் லிவர் அதே மாதிரி சாஃப்ட் லிவர் நீங்க கமிட் பண்ணிட்டீங்கன்னா ஹெப்படைட்டிஸ் அதெல்லாம் சொல்லுங்க. ஃபர்ம் அப்படின்னா கிரானிக் லிவர் டிசீஸ், அப்படின்னா மலேரியா, அது மாதிரி ஸ்டாண்டர்டா யூஸ் சம் டெர்மினாலஜி. சாஃப்ட் ஃபர்ம் அது டெஃபினெட்லி அது அப்படி ஒரு கன்சிஸ்டன்சி கிடையாது நிவேதா. ஓகே ப்ளீஸ் ஆவர்.
Spleen not palpable. What is the importance of spleen in this child?
Portal hypertension.
இல்ல வெரி குட். ஒன்னு அடுத்தது
important, very good. Can you get spleen in acute hepatitis A? How many percentage? And what is the grading of splenomegaly? You can get mild splenomegaly in 10-15% patients with acute hepatitis A. Okay. But when you have a spleen, firm liver, always keep underlying chronic liver disease. Spleen is always a sign for portal hypertension unless otherwise in children.
Yes.
Okay.
Yes.
Can you get ascites in hepatitis A infection?
Yes, very good. I just can you get oh, what is the possibility? Usually Niveda, what is your answer?
We can.
Usually,
We can.
Yes or no? If yes, what percent?
or no. If yes, why? If no, why?
If yes, in what percent? Okay, around 10 to 15% of hepatitis A, you can even get mild ascites. Okay, though it may not be very tense, it may be a mild ascites you may get. Okay, so splenomegaly and ascites doesn't rule out hepatitis A.
Okay.
Rarely you can get.
Ascites indicate decompensation, usually chronic liver disease. As we said, mild ascites can be seen especially when there is submassive liver necrosis or when there is superatoxic hepatitis. A child can have ascites due to A per se or due to A plus toxin. Some necrosis of the liver causing your second ascites can also occur in children, mild ascites due to hypoproteinemia due to prolonged fasting. They don't give any protein, only more sadam. And where is the source of protein? So underlying hypoproteinemia can also be further precipitated by your diet plus A. So these are the multifactorial, but you should say ascites is always a sign of decompensated background of chronic liver disease, but transient ascites can occur due to various mechanisms. Okay, good.
Go ahead. So you have got a liver, no spleen, yes, no free fluid.
Yes, ma'am.
Good, very good. Other system examination, normal.
I think,
Yes,
okay, good. She's got handwriting, I believe.
Oh, very good.
Very good. Okay.
Okay.
Yes.
Provisional diagnosis, 12 years old male child, firstborn of third degree consanguineous marriage, admitted with complaints of yellowish discoloration of eyes, high colored urine, pale colored stools, itching for the past 2 months, resolving at the time of admission, initially associated with fever, abdominal pain and vomiting, with past history of native treatment and oral medications taken for the above complaints, positive family history of similar complaints in his younger sibling, 2 weeks before the onset of our patient's complaints, with examination findings of icterus and mild hepatomegaly.
Start the adjective mild, soft hepatomegaly. Okay.
Yes, ma'am.
Okay, yeah.
A case of acute hepatitis with no features suggestive of portal hypertension, hepatic encephalopathy, or liver cell failure, probable etiology being infection.
Okay. Okay.
Yes.
Probability. Infection. Sir is asking, PRC sir has asked that child pushing out because the child has taken one native treatment. Does the child look pushing out? If child has been taking steroids for quite a long time, child sometimes might look pushing out. Was the child looking pushing out? Sir has asked one question.
No, ma'am.
No, it was not looking pushing out. Probably the native medication was not steroids, but something else taken orally. Okay. What are the features? If you 2 months, acute hepatitis is only 4 weeks.
Yes, ma'am.
So 2 months duration of illness, can you call it as acute? You want to call it as only acute hepatitis, infective etiology, probable hepatitis A, or you want to add on something to that diagnosis?
Toxin-induced hepatitis.
No, what madam is asking, what is the clinical
Manifestation.
diagnosis based on the history and
Subacute
findings?
hepatitis.
Still acute.
Acute hepatitis, yes, with, can you tell what is prolonged in this child?
Cholestasis.
So acute hepatitis, prolonged with prolonged cholestasis. Etiology is probably hepatitis A only, but because the child took some native treatment, the illness was probably prolonged. Okay. So acute, is it common in prolonged cholestasis? Is it common in hepatitis A?
It can, ma'am.
It can. It can.
Usually it's less common, rarely can occur, especially in the background of some drugs, whatever it is. And what madam is asking, there is one more entity. Suppose his child has recovered. After a few weeks, a few months, child coming once again with jaundice. What do you call it? A.
Relapsing hepatitis.
Relapsing
Very good.
hepatitis.
Relapsing type A hepatitis. Okay. And recurrent jaundice following A infection, always also keep, am I dealing with an autoimmune? Okay. On follow-up, not at this juncture. Okay. Very good.
Commonest cause of cholestasis in an infant or a neonate? Commonest cause of cholestasis.
Sepsis, ma'am.
Biliary atresia.
Extrahepatic biliary atresia is a commonest. Whereas older child, if the child cholestasis, what is the commonest cause of cholestasis? If cholestasis is rare, but if it occurs, what is the commonest cause of cholestasis?
Viral hepatitis.
Very good, excellent. Nelson clearly says viral hepatitis or toxic hepatitis. In your case, Viral and toxic hepatitis, both are there. That is why you had this prolonged cholestasis. Right? Okay, so that is the diagnosis in your child. Okay, that careful history taking has brought out that point in your history. That's very nice. Okay, okay, yes, proceed. Now, how do you want it? What are the investigations you want to do in this cell? Go proceed. Repeatedly, we were talking about acute liver failure, acute liver failure. Criteria for acute liver failure, I want you to tell.
Ma'am, a biochemical evidence of liver injury, ma'am.
Okay.
No known previous liver disease, ma'am.
No known chronic liver disease.
Chronic liver disease.
Excluded.
Prognosis which is not getting corrected by vitamin K administration, ma'am.
Proceed.
Then INR more than 1.5%, more than 1.5 in the presence of encephalopathy, or more than 2 in the absence of encephalopathy.
What is the definition of your?
Definition for acute liver failure.
Okay, yes.
Acute liver failure in hepatitis A is less than 1%, but you should know when the child is going in for acute hepatitis A. Okay. Now, what are the investigations you wanted to do in this child? Yes.
CBC with peripheral smear.
Rule out fever with hepatomegaly. So you wanted to rule out what infection, and you wanted to do a peripheral smear in that child.
Any hemolysis?
Hemolysis for malaria, to get malaria.
Okay. Can malaria cause your jaundice, hepatocellular jaundice, like liver enzymes elevation, dark bilirubin? What do you call that? You expect only hemolysis jaundice in general, but there is one entity called malarial hepatopathy, more common in falciparum infection, because the infected RBC can get attached to gastroendothelium due to cytoadherence factors, rule A formation, some amount of ischemic damage. They can have your jaundice due to hepatitis. Okay, that's malarial hepatopathy. And these are the investigation, first investigation. Suppose viral markers are negative, then only allowed for all the metabolic workup, not at the onset with slit lamp examination for K, ring, serum ceruloplasmin. Okay, because you have to tailor the investigations based on underlying clinical scenario. Everything is negative, then only I go for all this metabolic and even autoimmune workup. Okay, that's one thing. And what do we expect liver enzymes in this case? Usually acute hepatitis, usually it be more than
thousands.
Especially viral hepatitis. In my enteric fever and leptospirosis, you get mild to moderate 3 to 5 times, but not as you see in acute viral hepatitis in thousands. Okay, that's one important clue you should always see. More than PT in leptospirosis. Okay.
In leptospirosis, liver enzymes for example, madam சொன்னாங்க acute viral hepatitis liver enzymes வந்து SGPT வந்து thousands ல இருக்கும்னு நீங்க சொன்னீங்க. Supposing இதுவே ஒரு leptospirosis usually
in hundreds,
ma'am.
It is never on the thousands. Okay. If for example, or 2000 liver enzyme பாக்குறேன். Are you tempted to give NAC? Have you given? Do you give? Or
you can give NAC.
You can give NAC. 2000 liver enzyme பார்த்தா NAC கொடுக்கலாம். 5000 liver பார்த்தா can you give?
Yes, ma'am.
You can tell NAC is also recommended for paracetamol, but no, there are studies where used for even non-paracetamol induced liver injury because it's only a protective agent, but definite for your paracetamol toxicity. And there is one, I think the panelists have had one chat box. I think there's one answer. What is the mechanism for prolonged jaundice in this child due to drug? Drugs can cause prolonged jaundice due to hepatocellular involvement or due to cholestatic due to biliary involvement. Or even drugs can act as an ACT10 cause hemolysis, can have even confirmed hemolysis. So these are the various mechanisms for drug-induced liver injury. So it depends whether it is biliary, canaliculaar cholestasis, or due to hepatocellular cholestasis, or due to superadded hemolysis and whatever it is. I think you can proceed, I think, madam.
There's no need for giving NAC.
Yes.
Enzyme is 1000 or 1500. It's a self-limiting. Nalla liver enzymes elevated, automatically it will come down if there's a hepatomegaly. But child becomes sick, the liver enzymes are disappearing, liver is also shrinking in size, that time you'll have to be worried. Otherwise, it's not routinely not given. Dengue கூட நம்ம 5000 மேல போனதா NAC ஒருவேளை we can give அப்படிங்கிற மாதிரி WHO indication இருக்கனால it is not non-paracetamol poisoning வந்து not necessarily that you should give NAC. Don't be tempted by it. And you wanted to do leptospirosis MAT for this child. Okay. Why did you want to do? You wanted to do MAT as the investigation you wanted to do to rule out leptospirosis. What is the disadvantage of MAT? Why did you want to do MAT? Okay, you wanted to rule out leptospirosis, but why did you select that particular investigation, MAT?
It is confirmatory.
Gold standard, select okay, but MAT had a problem. And what is the problem with MAT? Are we doing MAT regularly? You are in a medical college hospital, okay, you can do it. But what is the problem with MAT? If supposing you take MAT for you, can you be positive? Asymptomatic individuals, can they be positive for MAT? Antibodies can be positive. You can be positive. The gold standard investigation, MAT is not widely available. Leptospirosis, we don't, I mean, if you get MAT, okay. But otherwise, what more commonly we do is, what investigation we do to rule out leptospirosis?
MSAT.
MSAT.
MSAT is a screening test. Screening na ninga pandrenga positive negative. It's a screening test. It is not effective. It is not just a screening test. No, it is not. MAT and MSAT is not.
IgM
Melissa for leptospiro, probably 85 to 90% you might have a sensitivity specificity. So you do IgM Melissa more commonly. MAT is available in central medical college hospitals with central lab facilities. Okay, so it is not available throughout. MSAT is a screening test. Apart from this, for leptospirosis, we also try to do our modified Fain's criteria, which incorporates clinical, laboratory, and epidemiological criteria to confirm leptospirosis. Okay, since you had written MAT, I wanted to talk about it. Okay. Then
prognostic factors, liver enzymes. Suppose you see 2,000, 3,000, even 10,000, whatever it is, and suppose there's a rapid decline in liver enzymes, and increasing INR is a bad ominous sign biochemically.
Yes.
There is no further liver cells to undergo further necrosis. There is a rapid decline, and coagulopathy, increase in INR is a ominous sign. This is very important based on that. And globulin, especially as Madam said, the disease of exclusion, absence of metabolic, viral, drugs, whatever it is. And if you see very high gamma globulin, more than 3.5 gram per deciliter, always keep an autoimmune liver disease, especially when other things are negative and prolonged hepatitis. Am I dealing with autoimmune? Then you can proceed for autoimmune marker after ruling out other conditions.
Okay, and Niveda, again here, this one you have for why did you want to do serum ceruloplasmin?
Since he is in the age group of common age group presentation of.
No, what was the purpose? What was the purpose of doing serum ceruloplasmin? You wanted to rule out what?
Wilson's disease, metabolic liver.
What I want to ask you is whether serum ceruloplasmin alone can it rule out Wilson's disease?
No, ma'am. 24 hours urinary.
Serum ceruloplasmin no use. Okay, what is the value?
Acute phase reactant. Serum ceruloplasmin is alpha to globulin, which is an acute phase reactant. Any acute hepatitis or any acute inflammation, serum ceruloplasmin may be even elevated. You cannot jump and tell this child is not having Wilson disease because of very serum ceruloplasmin. Similarly, when there is hypoproteinemia, the serum ceruloplasmin may be low. You cannot tell this patient has got Wilson disease. These are the corollary on the bracket. You have to just always analyze on the clinical context. Okay, serum ceruloplasmin plus K-bring positivity, then you keep a Wilson disease. Okay, or urinary copper. So these are the few. Like always, it's not a single gold standard test. We always go for a constellation of clinical findings, the history, along with the triad of your investigations. Everything is negative only. We have to go for your biopsy. So
okay, now if you are allowed to do all the investigations, how will you 100% rule out serum Wilson's disease? What are the 4 investigations you need to 100% rule out Wilson's disease? One serum ceruloplasmin less than how much?
20 milligrams.
20.
24 hours urine copper more than
40 micrograms.
40.
Okay. Still, if then what else you want to do? That these 2 are enough.
K-free.
K-free.
Okay. K-free present. Serum ceruloplasmin less than 20, urinary copper 24 hours urinary copper more than 40, more or less clicks the diagnosis. Then anything else?
Liver copper, ma'am.
Liver bio copper.
Liver copper.
No, liver copper we don't estimate. It's a very
serum copper.
What are the serum copper? We don't do generally, but what do you expect? What copper you do? Is it bound copper or a free copper?
Free copper, ma'am.
Okay, it's not a bound copper. Okay.
But Anna, liver biopsy la pandradhe illa doctor. Or we go for what?
Cellular plasmin, 24 hours urine copper after depenicillin challenge. Suppose it is very high, we just treat. Okay.
Okay.
That alone itself is good enough to diagnose very high urinary
I
copper.
to understand what madam is telling. 24 hours urinary in the moon, 24 hours urinary copper. We give a depenicillin challenge. And if it after giving, we again estimate the copper excretion, and that itself is the liver biopsy, because liver biopsy carries the risk of mortality. 1% risk of mortality in aim. We don't want to do an invasive procedure, but this is advanced enna pannalam ipo innum enna panna aarambikirom nama
genetic testing.
Now it is now we have started doing even idella pannittu still you are little hazy, go for even genetic test. Idellathiyum vachittu then we make. But before, while we are doing all this, but still you have basically you feel this child is having liver disease, Wilson's disease. Anything else you want to immediately, what would you like to start on this child? Treatment late aite irukudhu, but still you would like to start something for the child. What would you like to start for the child?
Zinc therapy.
Zinc, ma'am.
Yeah, we always start them on zinc. We wait for depenicillin before confirming the diagnosis. Excellent. Okay, you can proceed. Okay, yes. Yeah, if supposing your index case neenga serum Wilson's confirm pannenga, what else you will do?
Sibling screen.
Very good. Sibling screening, sir, as also you have to screen the sibling. Okay.
Yes, very
And
good.
you have some liver. Okay. Some spleen, whatever it is, anemia. Always investigate. Okay. Sometimes it's needed. If everything is negative, but still you strongly suspect Wilson a child of even asymptomatic. Sometimes you may need to resort in a liver biopsy.
Screening the sibling, very, very important. How many percentage of siblings are likely to have the disease again?
25%.
25%, ma'am.
Yeah, so mandatory, you should screen all the siblings for Wilson's. Diet advice in Wilson's, what will you do? Ennalam avoid panna solluvenga?
Nuts.
Copper containing foods.
Like
Chocolates.
chocolates, nuts,
Milk
Shellfish
product.
all your seafood, yes, good.
and liver.
Organ meat, like
Liver.
our liver. The liver of even a goat or whatever, no, like organ meat also contains copper. So organ meat should be avoided. Seafood should be avoided. Chocolates, nuts, your mushroom. Okay, all those things should be avoided.
Oh, very good.
Sibling is very important, and tell the mother to use only, not to use copper containing vessels. You can use your stainless steel or aluminum vessels. Okay, and sibling screening is very important. Very good.
Oh, very good. Proceed.
Ultrasound, what do you expect in this patient? Acute hepatitis, what's the role of ultrasound?
இல்ல முக்கியமானது விட்டீங்க பாருங்க, இந்த வைரல் மார்க்கர்ஸ் நீங்க சொன்னீங்க, இந்த இன்ஃபெக்ஷன் கன்ஃபார்ம் பண்ண வாட் இன்வெஸ்டிகேஷன், வாட் யூ வாண்ட் டு டு, வாட் இன்வெஸ்டிகேஷன் யூ வாண்ட் டு டு? ஹெப்படைட்டிஸ் ஏ என்ன இன்வெஸ்டிகேஷன் உங்களுக்கு வேணும்?
Anti-HAV antibody, ma'am.
Anti-HAV
ஆன்டிபாடி. என்ன
IgM antibody.
Be specific. Anti-HIV IgM antibody. For example, இந்த சைல்ட வந்து நீங்க பார்க்கும்போது டியூரேஷன் ஆஃப் இல்னஸ் எவ்வளவு இருந்துச்சு?
2 months.
What do you expect?
And was it positive for this child?
Yes, ma'am.
It was positive. So IgM ங்கிறது acute infectionல increase ஆகிற infection. IgG you take it for a longer period. So you should know how long this IgM can persist in a child with hepatitis A. Supposing child gets the infection, IgM persists for how long?
6 months.
6 months.
Excellent. Very good. Excellent, Inamadi. Very good. It persists for 6 months. IgM persists for 6 months. Very good. You have where if you wanted to rule out hepatitis B, enna screening investigation enna பண்ணுவீங்க? Immediately what will you do?
HbsAg, ma'am.
HbsAg, and you never do it alone. Okay.
And anti-HCV, ma'am.
Anti-HB? Correct.
CIgM. Anti-HbCIgM, ma'am.
And HbsAg, anti-HB C you will do immediately. Okay. You have done an ultrasonogram abdomen, and to look for what?
Hepatomegaly.
Okay. Coarse-echo textures இருந்துச்சு அப்படின்னா என்ன ஆகும்? And it indicates child is probably going in for chronicity. Okay. Yes, go for the next one. Next one.
Ultrasound abdomen acute hepatitis, you can have peripolycystic edema. Gallbladder can be sometimes even distended. Okay. Now in entry you can get A-calculus polycystitis. Echoes will be normal in acute hepatitis, unlike as madam said, hyperecho liver in chronic liver disease. Look for any spleen, look for any collaterals. Hepatitis with chronic liver disease, but in acute normal liver echoes And with very polycystic collection, always keep an acute viral hepatitis. Sometimes
Acalculous cholecystitis is very, very common in hepatitis A infection. Very common finding we can get. It is not specific for hepatitis A also.
specific, you can get even endemic hepatitis A.
Any other infections also you can get it. Very good. Okay, proceed. Next. Next, what other investigations you wanted to do? Thank you, Pottingla. Okay. Can you have a look at the investigations which the patient had? And can you come to some inference? Okay, yes. CBC, normal, 7,700. Okay, CBC வந்து ரொம்ப back 14,000, 15,000 elevated இருந்தா என்ன infection likely?
PT is not very much, no? 91, 41.
Yeah, okay. இத வாங்க டாக்டர்.
Recovering, must be a recovering phase. Okay.
See, in the initial investigation gives us some clue as to what is the problem cause. This here, what is this value? OT is more elevated than PT. That indicates what? That gives you a lot of clue, and we are right with our diagnosis.
What are the conditions for OT will be more than PT? That's what madam is asking.
Wilson disease. Wilson.
Very good. Wilson disease. Number 2.
Chronic liver disease, ma'am.
Okay, not for pediatric patients. Okay, number
Ischemic
3.
hepatitis, ma'am. Ischemic hepatitis.
No, ischemic. Dengue, you can have OT more than PT because of muscle involvement. Wherever you get hemolysis, RBC or muscle involvement, you can get OTPT. So leptospirosis, dengue fever due to muscle involvement. Okay. Then Wilson disease, any drugs that causes mitochondrial injury, because SUOT is a mitochondrial enzyme. Okay. So like even any drugs, probably this patient had been exposed to some drug-induced liver injury apart from alcohol in adolescent.
But you just nailed it. Drug-induced hepatitis for us, in the condition, so many conditions may be there. This child, see, your PT is less than OT-PT ratio is more than 1. You always can think in terms of drug-induced hepatitis or toxic hepatitis. This child started as acute viral hepatitis, but when it came to you, it had also drug-induced hepatitis because OT, as Sumati madam said, it is a mitochondrial enzyme. So it is more affected in drug-induced hepatitis and your toxic hepatitis. Whereas infective hepatitis like viral hepatitis, it is released from the cytosol of the PT is from the cytosol of the hepatocytes. So it is more elevated in case of viral hepatitis. So this gives you a clue to that this child had acute viral hepatitis superimposed with a toxic hepatitis. Okay. This elevated alkaline phosphatase was there, cholestasis, but it persisted for a long time. And again, very happy news about this child is the synthetic function of the liver was not at all affected. Okay. See, look at the serum protein globulin and INR. What happened to the INR? Normal, 1. Okay. INR value is probably 1 or less than 1 normal. So this child has never gone in for chronic liver disease. So this age. And you have done an ESR to rule out autoimmune hepatitis probably.
Even the direct, indirect is always like biphasic type of jaundice, no 20.4, 10.6. Concomitant hemolysis can also be kept in mind. Some of the infections where hemolysis can occur can have your both indirect component as well. So these are the few important clues. All the drugs that cause mitochondrial injury, just keep a list. Okay, for infections. Okay, yes.
This is your last slide. Okay. Anything more we need to add? Okay. Ultrasonogram abdomen. Hepatitis A IgM is positive. 3 months positive. Hepatitis B was negative. HIV was non-reactive. Where did you go do HIV?
That's what.
Okay. Okay. Serum ceruloplasmin 40 and normal. Okay, good. So your diagnosis finally is acute
hepatitis with prolonged cholestasis, probably due, it is due to hepatitis A.
Okay, thank you. Very good. Can you just stop sharing? You did all 3 of you answered most of the questions and you did a very good presentation. I really congratulate Niveda, Ilamadi and Ansil. You stop sharing. And one small, have you stopped sharing?
Yes, ma'am, I have stopped, ma'am.
Yes.
Ma'am, I have stopped it.
Okay.
In the meantime, one of you, can you answer about the hepatitis A vaccines? What are the 2 types of vaccines available?
Inactivated vaccine and live.
Okay. So how many doses for each vaccine?
For inactivated vaccines, 2 doses.
Okay.
First dose minimum at 12 months, ma'am, followed by
Okay.
second dose at the interval of
18 months.
9 to 18 months, ma'am.
Okay, 6 to 18 months. You can give it as early as 6 months or up to 1.5 years. Okay. What about live vaccine? How many doses?
Single dose.
WHO recommends single dose, ma'am.
Single dose.
Okay. IAP
recommends 2 dose of 6 months interval, ma'am.
Okay. Okay. Madam will continue.
No, this is only, I am just reiterating these facts. We have already spoken about this, but sometimes you might be taking these slides. That's why I want. What do you mean by certain terminologies? I am giving you the definition. For example, please follow IAP standard treatment guidelines for acute hepatitis. It's very good. Recently it was released. I think none of you have gone through it because many of the questions which I had asked was from that only. Acute hepatitis, the definition is it's a clinical syndrome characterized by acute onset of liver dysfunction, usually over a period of 4 weeks, characterized by elevation of transaminases. OTPT will be elevated, but you need not, your synthetic function, for example, your INR and your proteins need not be affected. On the other hand, chronic hepatitis refers to chronic elevation of transaminases, but there is no specific time limit. Acute is less than 4 weeks. And acute liver failure, you people answered rightly. There should be no evidence of a known chronic liver disease. There should be hepatic-based coagulopathy that is not corrected by parent K vitamin K. And hepatic encephalopathy should be present if the INR is between 15 and 19.9, 20 seconds, or 1.5 or 1.9 respectively. Hepatic encephalopathy is not required if PT is more than 20 or INR more than 2. This you people answered correctly. And Wilson's, we repeatedly this question we asked in the examination. What are the various clinical presentations of Wilson's hepatic manifestations? It can be elevated transaminases, it can have acute hepatitis, it can have hepatomegaly, it can present with fatty liver, acute liver failure with hemolysis, it can present with portal hypertension or with decompensation. And diagnosis of Wilson, KF ring should be present, serum ceruloplasmin less than 20, 24-hour urine copper more than 40, liver biopsy for copper more than 250 microgram per gram of liver tissue, and counseling and sibling screening is mandatory. These points I wanted to reiterate, so I'm posting it as slides. And autoimmune hepatitis also you answer. One minimum of 1 elevated transaminase, AST or ALT, with 1 positive lab test. It can be either elevated IgG gamma globulin or serological markers should be positive. And most important is exclusion of other viral diseases. Thank you. We have a scoring system for that also, but you can always go through it. Thank you. Now I request our Sumati ma'am to give a short summary of the approach to acute hepatitis. I'll stop sharing, Sumati. Arish, yes. Yeah.
I think
Yes, we can-
all the postgraduates for the excellent disposition of the case, along with Lakshmi Madam and Sri Devi. Madam, as usual, she is very, elaborated very nicely. I think my job is made very easy. Next, I just going to give only brief outline, how to approach.
Slideshow போட்டுருங்க madam.
1 minute. Yes.
Yes. But slides are not seen.
Wait, please. So clear, madam, is it on
a slide?
Yes. Pathological introduction, I think we are typing. Okay. Not going to that, so it's not uncommon. Always stepwise approach is very important. Am I audible?
Yes, audible.
So always look for the red alarm signs as mentioned. Good history and physical examination is a must. And the treatment is in acute hepatitis due to infection is always specific, supportive and specific if there is any tropical infections. And the prognosis always depend upon the etiology, the presence of complications, the referral time, and timely management. And most important is always underlying nutrition status in pediatrics. And pathological approach, am I dealing with hepatocellular jaundice or cholangitis due to hepatomegaly involvement? That history should always keep in mind. And the infections has been mentioned in detail, all the hepatotrophic infections, non-hepatotrophic infections, tropical infections in India, upon drugs and autoimmune diseases. So always assessment is very important. Fever, with chills. Always keep sepsis in young infant, malaria infections, cholangitis due to obstructive jaundice, biliary ascariasis, your stone disease, strictures, or any even node compressing on the biliary system can cause your obstructive jaundice with cholangitis, though it's less common. But keep epidemiology ascaris is one important always in a cause of cholangitis in pediatrics. And prolonged fever always keep hepatitis E and co-infections with hepatitis A with other infections in the tropics. Don't forget your macrophage activation syndrome. They can have prolonged fever, and always keep any other systemic involvement as you see in autoimmune and Wilson disease. And transient elevation always keep some of the common acute infectious conditions. And don't forget to examine the child for acute liver failure, both by history, the clinical examination, as well as by the biochemical parameters. And the pathogenesis is always a multifactor. Any infection can cause direct injury of the hepatocyte. It can cause immune-mediated damage. It can cause ischemic damage, as you see in dengue. It can cause endotheliitis, rule formation, as in malaria infections, malaria hepatopathy. As mentioned, the drugs can cause your drug-induced liver injury and co-infections. That is more common, especially in our country. Sometimes a long fever always keep A with lepto, as mentioned, A with malaria, enteric, whatever it is. So the step one approach is always the onset, the prodroma, the duration of fever, the family history, and the travel history. Travel history is going to give a clue. You know, some of the infections and drug intake, the offending agent, as mentioned in detail. As children, immunocompromised children are prone for even the long jaundice due to A can occur in immunocompromised child, or long jaundice can even cause your complications. Unusual organism is more common in immunocompromised. Even fungal hepatitis can occur, and complications are more in immunocompromised children. As mentioned, CMV, fungal infections, and recurrent polygenic infections can cause in children who are immunocompromised. Look for the red alarm signs: deep icterus, altered sensorium, reversal sleep pattern. When you're doing rounds, child is sleeping during daytime but not during the night. It is an early sign of your hepatic encephalopathy. But there is a difference between HE, that is hepatic encephalopathy, versus your encephalopathy due to acute liver failure. Because in acute liver failure, the previously child was normal, there is no underlying liver disease. So it is acute liver failure where the encephalopathy, whereas in hepatic encephalopathy, it occurs in background of chronic liver disease where use the terminology HE, whereas ALF is used for an acute liver failure with encephalopathy or coagulopathy. So there's a basic difference. Look for the shrinking liver in case of routine bedside examination. When you're seeing a case of acute hepatitis, look for any increase in serum bilirubin, rapid decline in serum transaminases, increasing INR, as mentioned usually. So clinical approach, I told you anemia, splenomegaly, malaria, macrophage activity syndrome, or rickets cells, scrub, whatever it is. Jaundice can be due to liver injury, hemolysis, or biliary obstruction. Second week, jaundice is common, enteric fever, neuropsychiatric manifestations can occur, Wilson disease. Some of the lepto can have some of the CNS involvement, enteric can have some encephalopathy. So always look for the other system examination. Bleeds in the eyes, subcutaneous bleeds can occur with leptospirosis. And toxic child with hepatomegaly and soft spleen, a rose petal spleen, think of enteric fever, eschar in your case of your scrub typhus, rickets infections, rash can be due to drugs, autoimmune, macrophage activation syndrome, hepatitis A, sometimes even B and even C. Rashes can occur. Okay. And DAVC usually in sepsis and multi-system involvement due to other infections which are very, very no less common, can occur in pediatrics. So look for the eyes, look for the subcutaneous bleeds, look for the eschar, look for the rashes, dengue rashes, look for your HLH rashes. Okay, your macrophage activation syndrome secondary to some infections can be viral, bacterial, whatever it is. Then if you have other system, rhabdomyolysis can be seen with your dengue fever, leptospirosis, myocarditis can occur with viral infections, myalgia can as usual can occur with lepto and dengue, conjunctival bleed, whatever it is. And multi-system involvement, as said, it can occur due to autoimmune liver disease, can occur due to DL infections, A with other malaria, can go in for kidney failure. Similarly, you can get Wilson disease can present with multi-system involvement. But infections per se, when we have multi-system involvement, give some of the common infections in children. So dengue, I told you, the liver injury is variable, can be direct cytopathic, immune mediated, ischemic. But ischemic injury usually have very high OTPT. And most of the time it is always the anecdotal hepatitis with mild to moderate elevation. You don't see much of jaundice in dengue fever. The exact reason are not known. The necrosis, what we see is always zone 2. It's like what is seen shock. And jaundice can occur 15%. If jaundice occurs in dengue, it indicates poor prognosis. That means if there is a capillary leakage syndrome, LFT 10% will have raised transaminases more than 1,000, whatever it is. And as mentioned, SGOT will more than SGPT in dengue fever. Leptospirosis, as I said, it is always a biphasic. They can have endotheliitis, they can have mild to moderate elevation of liver enzymes. They can even present with acute liver failure as well. Leptospirosis ectohemorrhagica. Sometimes they can present with acute liver failure. Liver abscess, don't forget, fever with jaundice, always keep abscess, a toxic child, tender hepatomegaly, rub-on auscultation. Always keep, am I dealing with liver abscess can occur in immunocompetent or even immunocompromised child. Okay? The risk factors always as mentioned. Some of the immunodeficiency syndromes, both congenital and acquired, even HIV. Fever, rigor, chills, tender hepatomegaly, keep liver abscess and extrahepatic obstruction as well. Macrophage activation syndrome, jaundice can be persistent. They can present anemia and pancytopenia. That gives a clue in investigations. CBC, leukocytosis for malarial parasite, eosinophilia in a case of drug-induced liver injury, ESR may be elevated in abscess, autoimmune liver disease, LFT, look for a OTPT, your AG reversal if there's unlike chronic liver disease, very high gamma globulin exclusion of your viruses, metabolic, toxins, gamma globulin is very high. Then think of am I dealing with autoimmune liver disease, always screen for the markers, especially A, E in our country and B and C in select situations with multiple transfused children. And dengue serology, we are suspecting during season leptospirosis based on the clinical curve depending upon that underlying clinical suspicion. So laboratory approach, always I said, look for the albuminuria, can occur in your lepto. That gives an indirect clue as well. Hemoglobinuria, intraocular hemolysis, malaria hepatopathy. Okay, some of the things. And bone marrow, you need only in your HLH, macrophage activation syndrome, not routinely. So biochemical, very high OTPT. I said 3 conditions: drug-induced, viral hepatitis, and your ischemic or the shock liver. Raised serum bilirubin with normal aminotransferase is highly suggestive leptospirosis rather than hepatitis. Anemia, malaria, whatever it is. Ultrasonography is not specific. Hepatomegaly, pericholecystic edema, distended GB, is getting acute hepatitis of varied etiology. For gallstones and biliary ascaris, we are suspecting cholangitis and extrahepatic biliary obstruction. Liver abscess, initial maybe even isoechoic or hypoechoic. After some time, they can have hyperechoic liver with heteroechoic, some shaggy margins, very echogenesis of the liver, sometimes collection, debris, whatever it is. Liver abscess, a large liver abscess on left lobe, be careful because the infant sign of rupture is very, very high. They can rupture into IVC. So large abscess more than 10 centimeter, abscess in the left lobe of the liver are very dangerous. We have to always get a surgical consult. And we have to go for a drainage procedures along with antibiotics. Leptomegaly nodes, keep your tuberculosis, though epidemiology tuberculosis is very, very rare, but can occur in country like here where tuberculosis is always endemic. And don't forget anatomical conditions like polydactyl cyst, pain, child can have jaundice due to cholangitis, the child can present with water like mimicking acute hepatitis. So sometimes you can pick up a polydactyl cyst in ultrasound. Hepatic fibrosis, though rare, cholangitis type is one entity of CHF. They can have 2 types. One is cholangitis type, another is port like pregnancy type. Cholangitis type, they can present with jaundice, they can present with itching, long jaundice. We see some cyst in the liver, some cyst in the kidney. Am I dealing with congenital hepatic fibrosis? That's very, very important. Rarely, the liver, kidney is enlarged, nodes are there, liver is there, spleen is there. Am I dealing with lymphoma? So management is always specific depending upon the infectious agent. Mainly, it is supportive or viral entity. Don't forget your treatment of your coagulopathy, avoidance of hepatotoxic drugs, and the diet, which is very, very, very important because you have to advise other to give adequate calories, proteins of vegetable origin, the normal recommended fat, because fat, very high fat, they can have nausea, but they can do seasoning. Cauliflower, they can do seasoning, they can add turmeric. They always think, can I add turmeric because is it going to aggravate the jaundice? Turmeric has got an antioxidant effect, is not going to do anything with the increase of jaundice. So tell the mother what to give and what not to give. Like deep fried oil item can even increase the nausea. They can have vomiting. Non-vegetarian diet to be better to avoid it during acute hepatitis. But once they recover, they can go into the normal diet as well. So take home message: systemic approach is very, very essential. Causes are heterogeneous, ranging from infections to non-infections. Probably infections are often implicated in clinical practice in our country. The involvement in various infections are variable, but very important is always look for the early signs of acute liver failure. Don't forget to look for any other rare metabolic conditions, whether positive family history, a sibling death, whatever it is, always think rarely they can present acute hepatitis. I mentioned risk factors identification very, very important. So this is the thing, always a common entity with various conditions. So a diligent examination with good history is always very important. Thank you for your patience hearing. I am congratulate all these postgraduates. The excellent presentation once again, and both the persons, my teacher, Lakshmi is my teacher as well. My colleague Sri Devi is my colleague. They have done an excellent job. I congratulate both of you.
Thank you.
Any doubt you can ask.
Madam, you are our.
There are few things, sir, has already mentioned. You have to read about all about A, E, the various modalities, the incubation period. What both of you said is wrong. Sir has mentioned chat box also because of the lack of time. I don't want to go into detail of every individual viruses. So, what's the difference between B and C? Why B is more dangerous? Because it's very, very highly infectious. And second, it gets integrated with the host genome. That is one thing. The hepatocellular carcinoma, even if you treat, they can develop HCC. One thing very important. What the drugs for C, when to give treatment. So all these things you can learn later.
Always protect yourself against HBsAg. As medical personnel, if whether you had your vaccine, if you don't remember, go check your antibodies less than 10, please. Your repeat vaccination is very, very important for, especially pediatrics, when we put repeated lines, transfusions, everything is very common in pediatrics.
Usually come, yes, they come with a nihilistic injury, they come, they run. Madam, yesterday I had a patient with the HBsAg positive, but the vaccination status not known. As madam said, if possible, you have to check the anti-HBs titer adequate, more than 100. Sleep peacefully. Less than that, you have to restart your schedule. That's very important. So immunization against B is very important, especially among the healthcare personnel. And always follow universal precautions, thinking is HIV positive, is B positive, C positive. That's one thing where you can prevent cross infections among patients as well, among the healthcare workers as well.
Thank you so much, ma'am, for the excellent moderation and continuing with us. I thank Sri for having coached her postgraduates very well and having conducted the session. In spite of this month being May, she has carried on with her academic work. Thanks a lot, Sri. I once again thank IAP TNSE. Special thanks to Rajendran sir for continuing this program for quite some time. I thank my judges Ramachandra Mohan, Professor Srinivasan sir, Ram PRC sir, and Ramesh sir for having asked a lot of questions, and hope we answered you, sir. Thank you very much, sir.
I thank all the senior faculty members, my teachers, PRC sir, Ramachandra Mohan, Madam Srinivasan sir, an examiner to ICC.
Can you stop slide sharing, please?
Excellent like coordination and bringing this.
Madam, slide sharing.
My special thanks to you and all your IAP office bearers as well.
Madam, slide sharing stop பண்ணுங்க madam. Sumati madam, slide sharing stop பண்ணுங்க.
Thank you.
Sir, on behalf of our students from Keelpark Medical College, I thank the IAP for the opportunity, and once again, I thank Sumati madam and Lakshmi madam for the excellent moderation and bringing out, coming with all relevant questions which are very much asked in the exams, and trying to be very encouraging and supportive and get the answers out of them. I thank the judges for their inputs. Thank you.
Yeah, thank you, madam. On behalf of IAP TNSE, I thank Antenatal for this wonderful presentation by Keelpark Medical College. Now I request our judges to come. Please, Dr. Srinivasan sir.
Yeah, the three Devis have threadbare analyzed and dissected the whole this thing, and the three students, they are looking more like undergraduates than postgraduates, but they did a wonderful job, and they answered all the questions. It was very educative and academic even for people like me. So I enjoyed the whole session. Thank you so much.
Thank you, sir.
For the best this thing, discussions we had so many. Okay, this is one of the best. Thank you.
Thank you, sir, for your nice comments. And Dr. P. Ramachandran. Sir, unmute, sir.
Sir, unmute.
Yes, sir.
Thank you.
Thank you, sir. It was a wonderful presentation. I just lost connectivity throughout at the end. So it's a really a good teaching session, sir, with excellent teachers like Dr. Lakshmi, Dr. Sumati, and Dr. C. Devi. Actually taking the students very well along. Yeah.
I was feeling like an undergraduate student.
Exactly.
The whole thing.
They were very, very encouraging. That is the hallmark of their, the way they taught. And they were giving a lot of important practical clues, not only they went beyond just a liver disease. As a general pediatrician, what are all the things you can expect during the interaction? So really enjoyed it. And it's really a wonderful teaching session. And the students also did very well. Congratulations.
I like the paracetamol question, what we will do immediately.
Exactly.
And, because so many doses are available, combinations are available. It's an excellent question and I enjoyed it very much.
Thank you.
Yeah, thank you, sir. Thank you. Now I request Dr. Ramesh, sir, from Chidambaram.
Sir, it's like a rapid fire session because of the high speed discussion, because all of them are ladies. They could cover such a vast topic within 2 hours.
With the ladies.
Excellent compliment by moderators and the chairperson. So, and Dr. Sumati has given excellent slideshow on approach to hepatitis. And Dr. Lakshmi was asking a lot of collateral questions. So one way it's nice because in the examination, the students keep on thinking about the particular case they're having. But very often the examiners ask questions related to that or they deviate sometimes. So you must be prepared for that. Do not be focused on just one case because the long case they assess your caliber and your knowledge and experience over 3 years. I think this was one of the best as process. Srinivasan PRC said one of the excellent teaching sessions. And Kilpauk Medical College students have done a really good job. And it's nice that all the 3 of the candidates are participating in the discussion. Thank you.
Thank you, sir. Now I request Dr. Rama Chandramohan, madam.
Yeah, what can I add to what has already been said? Nothing that it is perfect in all ways. The choice of the case, the way the PGs have answered, the excellent discussion by the teachers. Lakshmi, as always, is what shall I say? Rapid fire.
And other students also participated well.
Yes,
Mr. Ramesh always, used to tell only one person is answering. This time, all the 3 answered.
So all the credit to all the ladies involved, sir. All the 3 postgraduates and all the 3 teachers, all of them have done very well. I just wanted to know whether they should specifically mention that KF ring is seen or not seen in a clinical examination. Is that or shall we just, omit that part? I wanted to know that. And in this particular case, she said KF ring is seen also. So what it is written, her slide, it is written as KF ring is present.
Oh, okay.
And that was my doubt also, madam. Because
in gross examination, naked eye examination, KF ring was not there. In her head to foot, she said it is not there. Only on slit lamp examination, KF ring was made out.
Yeah.
Can you get it in hepatitis A, madam? KF ring?
Mention it.
You have to again send them to ophthalmology hospital to recheck whether that is there or not there.
Yes,
All the other biochemical parameters are normal. So sometimes they would have somebody would have seen. So we have to recheck the KF ring.
Exactly.
This say instead of
Actually, we sent the child twice. So, I mean, in our institute only, we didn't send it outside the institute. So we did the examination twice, and our ophthalmologist said KF ring is present.
Or maybe
Anyway, you have to keep a follow-up on this child. Even repeat the other investigations urinary copper later as well, because if the KF ring is strongly positive, you should not miss a Wilson disease.
So that is why we did the urinary copper post chelation only, post penicillamine only. We did the urinary copper that came out to be normal, and the child improved also.
I don't know whether they got confused with
Especially when there is deep jaundice, whatever it is, the 20. Even the pigment sometimes looks like yellowish due to deep jaundice, maybe mistaken for KF ring. And as Rama madam asked, generally we don't look for a KF ring, but if it is there, we should not miss it while presenting a case. But when the liver is formed,
also, madam.
there is minimal fluid, when there is strong family history,
Because it's
we
worth
should always
keeping a
mention
follow-up
there
of
is no
this
KF
child.
ring.
child should be under surveillance.
This time should be kept under follow-up, and then you must see
Yes,
whether
we
it
need to have a
becomes a
follow-up.
chronic disease.
Can be
Yes.
acute hepatitis manifestation of Wilson's also. He can become a possible case also. We do not know. Anyway, on the whole, it was
Sometimes Wilson also present as acute hepatitis.
yeah, that's what. So this
Yes,
may
one of the manifestations.
that's what. Ideal age and everything is fitting into that. That's what. Okay.
Yeah, thank you, madam. And now I request Dr. Janani Shankar, madam, please.
Oh, Janani. Hi, Janani.
Janani is not around, I think.
Actually, on okay. Because of IAP TNSC, really thankful to our Kilpack Medical College students. Yes, sir said, no, the three of them answered very well. And I thank Dr. Sridevi, she has made her PGs to prepare very well. That's actually this time the nice presentation also. And I thank, as usual, Dr. Lakshmi Velmurugan madam, ever endu, and usually will ask a lot of questions and as well as most related to exam also. I thank Dr. Sumati madam, today's chairperson, and as usual, she has done very well for case discussion also. On behalf of IAP TNC, I thank today's judges, Dr. Srinivasan sir, Dr. P. Ramachandran sir, and Dr. Ramachandran Mohan, and Dr. Ramesh from Chidambaram, as well as Janani madam to participate. And once again, I thank all the students to participate this event. On behalf of IAP TNC, I thank one and all for this opportunity. Thank you, sir. Thank you very much.
Thank you very much.
Dr. Rajendran, the standard of PG clinics going every week, it is increasing.
Good night. Yeah, good night.
All because of
a
you,
dynamo. Dynamo.
பெருமைகளாம் நம்ம ஐஏபிக்கு சேரும் and எல்லாம் உங்களுக்கு 6 judges and as well as
Tireless man.
எல்லாரும்
2 வருஷமா ஓட்டுறீங்க சார், நிஜமாவே பெரிய விஷயம் சார்.
Thank you.
All of us are benefiting, including the teachers.
We didn't have this opportunity nowadays, sir. Such an excellent discussion with the experts in the field.
Yes.
Thank you, sir. Thank you, sir.
Thank you, everyone.
Thank you.
Thank you. I learned a lot from all of you today.
Thank you, Srinivasan sir.
Good night, sir. Good night. Thank you.
Good night.
Thank you, sir and ma'am.
Thank you, ma'am. Thank you, sir.
Thank you, sir.